You so much, Ashley. So, hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series and thank you for participating. Before we begin, I'd like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees as you're doing now. Today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHUD's website as a resource. You will also receive this information in the post-webinar email that will be sent out through Zoom tomorrow morning. You can also visit NAHU's resource page on the website to find this resource and view the past sessions. Throughout the session, please use the QA pod to ask your questions. The speaker, Dr. Brian, will address them at the end of the presentation. If there is time and you'd like to ask your question live, please raise your virtual hand and I will open up your line to speak. So just to provide some background on NAHUD, for those who are not familiar, NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the AETCs. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care, and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the AETC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events, trainings, learn about ORN work groups addressing health disparities, and more. We value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session, and it will also be included in the post-webinar email. Please complete it within the next 2 weeks. Once the survey is closed, we are unable to reopen it. If you are requesting CE credit or a certificate of attendance, you will need to complete the evaluation. To receive contact hours for participating in the continuing education program, the registrant must join the webinar, attend at least 60% of the presentation, and complete and submit an electronic evaluation. You will receive your requested certificate within 3 weeks of submission of the evaluation. So just as a reminder for those who may be in the same room with other participants, you will need to log into your own computer and log in so that it would record that you did participate if you're looking to request any CEs today. So with that said, I have the great pleasure of introducing today's speaker. Dr. Loris Bryant is a solution-focused professional with over 30 years of experience in behavioral health and public health. He specializes in developing curriculum, educating medical providers, and providing technical assistance and training in areas such as substance use disorders, HIV and AIDS, health disparities, unhoused populations, and respiratory therapy. Additionally, Dr. Bryant is certified in methamphetamine addiction and is a qualified trainer in the use of Narcan. As a seasoned leader, Dr. Bryant helped develop and execute a statewide strategic plan for the opioid and prescription drug overdose epidemic in Georgia. With more than 20 peer-reviewed articles and numerous presentations at various conferences, his extensive experience as a registered respiratory therapist and behavioral health professional has thoroughly prepared him for teaching and performing in diverse academic, medical, social, and community spaces. Dr. Bryant has 34 years in long-term recovery. So once again, it's my pleasure to hand it over to Dr. Bryant.
Hey, thank you. Thank you. And even before we move forward with our presentations, we always have to acknowledge our leaders, those that are behind the scene, those who've worked diligently to make this presentation possible. And so I want to thank the National Alliance for HIV Education and Workforce Development. I want to thank Liz Lazo, who just has been a drum major in terms of the work behind the scenes, and also Ashley Johnson, who's the education coordinator, for her diligent work behind the scenes. And so as we move forward, again, we want to acknowledge those persons, just even in the culture that we're in and a lot of the stress that we're under. It's always important to thank the people who made this possible. So I'm going to go ahead and share my screen. And
awareness and
go from there. And let's go ahead and start from the beginning. Can everybody see the screen?
Yes, but Dr. Brian, you gotta restart from the first slide. There we go. Now you're in the discussion.
Yeah. Okay, let's see what happened there. Okay, let me stop sharing and start again.
Dr. Brian, just keep pressing back until you get to your first slide.
Yeah, that's what I'm doing. Okay, so again, this topic, HIV and substance use disorder among an aging population, is a very, very timely, is a very important topic. And for this time in the HIV/AIDS epidemic trajectory, it's also very, very relevant. And so I just presented on this topic at the U.S. Conference on HIV and AIDS. And just to tell you how important this is, the entire conference, one of the biggest conferences in the United States, actually in the world, felt this topic was so important that the entire convention or the entire conference was around HIV among elder populations. And so again, this topic is very, very important, but I also want to let you know that I see myself unfolding in this topic. So I am, as of July 13th, 1953, turned 72 years old. So I am an elder person. So I am part of that population. As Liz said, I also have the privilege of 34 years in long-term recovery. Definitely a part of the population. Also like to share, being totally transparent. I've been living with the virus for 30 years. Been thriving with the virus. I've been living my best life with the virus. And so I am fortunate to be able to say, not only do I bring to you this professional side of me, but also I'm willing to be totally transparent and share my personal journey with you as well. And in addition to living with HIV for 30 years, I also have been cured from hepatitis C for 25 years. And so I am the person that we're going to be talking about, and I don't mind sharing my experience, strength, and hope as we move forward. I have no disclosures at this point, and so I just wanted to make sure that you all were aware of that slide. So just in terms of our objectives, so yeah, I've got a plethora of slides. I'm not necessarily going to go over every single slide. That's not important because you'll get the slides at the end. But I want this to be an interactive session, particularly as we watch what I consider one of the most phenomenal videos that I could find on HIV and long-term survivors. So we'll get to that slide very shortly. But we want to really look at issues related to HIV and aging, and we want to be careful of our language. We don't want to say seniors. We want to say aging or those that are maturing with HIV. We'll discuss factors related to substance use disorder and aging among those with HIV. We'll identify some current research and evidence-based strategies as well in terms of person living with HIV. And we'll go over some treatment modalities as well as community resources, as well as providing for you some resources that can help you change the way that you do what you do as you're interacting with your clients, with your patients. You want to be able to use this information to make changes to have impact on your population, as well as to make outcomes for our populations more of a reality. And so the first thing we want to contextualize what it is when we're treating elder populations. And when we're talking about elder populations, we're really talking about those for this purpose. We're talking about those that are 50 and older. And so whether you are a counselor, whether you are a physician, a social worker, if you are dealing with this elder population, here are some general kinds of practices that are very, very important. We call them the 5 M's. And each M stands for something particular. So you've got mind, you've got mobility, you've got medication, you've got multi-complexity, and you've got what matters. So these are the 5 areas, regardless of where you work, what your profession is, when you're dealing with this population, these are the things that are concerning. So when we talk about mind, we really do have to be cognizant of and concerned about cognition. Issues around, for example, dementia, and really being aware of and assessing for that in this population. Other areas such as delirium, really just making sure that their cognition is evaluated, and also around areas of depression and anxiety, those kinds of things. So that's the first M. The second M that is just equally important is mobility. Assessing and evaluating their ability to be able to walk, to be able to maintain balance, and preventing falls. So even for myself as a 72-year-old person that is living alone in an apartment is very, very important. And so recently, I had to give up my support animal. His name was Buddy, my dog. And I've had Buddy for 10 years. And so, but as he's gotten older, he was going on 12 years old, he was unable to hold his urine. And so he just started to, urinate throughout my apartment. And one day I came home and I didn't realize that he had urinated, and I took a horrible fall. And that could have been devastating because I have these little statues like on the side of my wall. And fortunately, I didn't fall into them. But if I had that could have been pretty devastating for me. And so that really scared me. So I said, okay, well, hopefully this doesn't happen again. Well, it did happen again. I came home while I didn't fall. Um, my foot I slipped and my foot went into the wall and I almost broke my middle toe. So I really had to make a decision to take Buddy back to the rescue place where I got him from. And they were more than willing to take him so that he could be in an environment where he had more sort of space and outside and that kind of thing. Because I live in a high-rise apartment and that just was not feasible. But just in terms of safety and being able to Make sure that your living space is safe. One of my other concerns is getting out of the shower and making sure that there are pads down there, so that would help prevent slips, that kind of a thing. But also being able to be mobile enough, for example, to go shopping, to go where you need to go, just in terms of your daily activity. So certainly those are things that are concerning. And just going back to mobility, I have a variety of different kinds of co-occurring conditions. And one of those just recently, within the last couple of months, has been pain in my lower calf area, which prevents me from walking now more than a block. And so if I have to travel, for example, flying, that kind of a thing, now I'm literally in a wheelchair. So just really assessing those kind of things, monitoring those kinds of things, so that we're making sure that their mobility is as appropriate as it can be. Also, medications, reducing polypharmacy. And that's another thing. Many elderly persons are on multiple prescriptions. And so making sure, number one, that your doctors are aware of the prescriptions that you're taking, making sure that they are aware of any potential interactions of these prescriptions. And this is something that I've had to face within the last couple of weeks, is making sure that medications that I've been on for years, assessing whether or not I still need to be on them. Do I need to be on one medication for 30 years and nobody has evaluated it for the entire 30 years? And so there are a couple of medications that I've actually been able to stop using simply because my doctor and I had a conversation around the need to continue this medication. But just as important, making sure that there are no adverse interactions in terms of the multiple medications that one may be taking. And also multi-complexity. And that's really looking at what other conditions may be concerning for your patient or for your client. Assessing conditions where they live. Do they have appropriate kinds of mechanisms within their living quarters that would sustain whatever their needs may be? And I think this is probably one of the most important M's, and that is what matters most to the patient. Looking at whether it's finances that matters most, is it family issues that matters most? Have they identified other conditions such as substance use disorder or alcohol use disorders? What other things are they concerned about? Are they concerned about paying their rent? Are they concerned about an illness? For example, another one of my co-occurring conditions is sleep. I've been diagnosed within the last couple of months with severe sleep apnea. So how does that impact one's life? What is it? Because sleep, we know, particularly in an aging population, is very, very important. And so I think I'm headed in the right direction. I've had some really, really bad habits that I've adopted over the years, and my primary care physician recommended a psychological sleep therapist for me, which is something I'd never even heard of. But let me just tell you, within the last couple of weeks, my life has changed dramatically. She gave me an entire sort of program where, and this is the biggest thing that's made all the difference. She said, and I had been told this before, but never really took it seriously. She said, the only thing that I should be doing in my bedroom, in my bed, is sleeping. That's it. So the eating in the bedroom, watching TV in the bedroom, doing my computer work in the bedroom has stopped within the last week. And it takes time to change behavior, but I'm actually, moving in the right direction. I've been, recommended a CPAP machine, which is for to help with sleep apnea, and I actually have gone back to using it every single night. And I tell you, I had not in the past been able to get more than 4 hours sleep. Well, within the last week, I've gotten 5 to 6 hours sleep. And I tell you, that's why I'm so passionate now. That's why I'm so vibrant now. Last night I got about 5.5 hours sleep. So sleep is very, very important. And just being diligent with that is equally important. So let's just change trajectory just a little bit. Let's look at HIV among an aging population. So just in terms of contextualizing the population, in 2025, older adults represented a very, very significant part of our population. In fact, by 2030, 70% of persons with HIV will be greater than 50. Back in the 70s, that was unheard of. I have really been in the field, even as a respiratory therapist, been in the field of HIV for over 40 years. If we go back to 1979 in Los Angeles, California, as a respiratory therapist, I saw white young men come into our respiratory intensive care unit at Cedars-Sinai Medical Center in West Hollywood, and they would go on ventilators because they would have this pneumonia that just was atypical. Now we know it's pneumocystis pneumonia, but it would be vociferous to the point where many of them did not come off ventilators and many of them died. But this was even before the 80s, before really the whole issue of HIV really became a national topic. And so back then, the healthcare system was turned upside down. And we progressed very significantly in a lot of areas, but in a lot of areas, we have not. And so Health HIV reported that in 2022, an estimated 54% of the nearly 1 million people, so the 1 million people living with HIV, but 54%, over half of the people living with HIV are over 50. So we represent a significant part of the HIV epidemic. And over the years, our population really has been underserved. They've been overlooked. And we are fortunate now that we are beginning to take this issue as very, very important because, again, our population is aging. So I wanted to just take a look at some pretty formative research that has been done in Health HIV. So Health HIV basically did an annual, or their fourth annual national survey. And this was a fairly comprehensive survey that looked at aging with HIV. And so this was done in 2024 between August and September. And literally, they did qualitative research interviewing 907 persons. So again, this is pretty comprehensive. You're talking about 907. And they looked at areas around, for example, psychological needs, healthcare needs, financial challenges, access to healthcare, the quality of life. And those are just a few of the areas. So again, this research was really, really comprehensive. And they came out with a very, very comprehensive report. And I think that I put the link in this slide in terms of the report. But here are just some of the things that came out of the report. One of the things that this population was most concerned about is the issue of frailty. And so frailty really is the presence of 3 or more unintentional kinds of issues. So issues around weight loss, self-reported things like exhaustion, fatigue, weakness, which can be measured by grip strength, those kinds of things. So that was important. And many of them said that that was not something that their providers did for them. So frailty is considered a very, very important element because what it does, it really allows an early identification of a potential declining health. And so again, that's very, very important. And just going back to the 4 M's, and when we look at mobility again, in this population, a third of them experience difficulty with balance, um, physical activities due to HIV, but 3/4, 1/3, said that they were not screened for frailty or falls within the past year. These are two elements that are extremely important, both part of the 5 M's, but yet many providers do not assess for that. And again, I just can't tell you how important mobility is, and you really don't realize how important it is when you, unless in some capacity, you are limited in your mobility. And here's the other thing: um, I had problems for a while not being able to drive at night because of my vision. And they diagnosed me with, I guess, called stigmatism. And so, that was pretty limiting for me because, after dark, I just could not drive. Well, I shared this with my provider. My provider recommended, ophthalmologist. And long story short, I had surgery on my eyes. And I tell you, it was like a miracle. I mean, I could see things like without glasses that I had not been able to see long distance for years. Now, what was compromised is my reading. And so I've had to use reading glasses, but I'm okay with that because I'm able to drive at night. I'm able to see clearly now. I'm able to go anywhere that I want to go. What does still limit me in terms of mobility is the sleep apnea. And one of the things that I don't do, I don't drive long distance. So if it's longer than 2 hours away, I just don't drive that distance because I just don't trust that I may become sleepy or fall asleep. And so, again, really, really keeping an eye on these co-occurring conditions is extremely important. One of the other, and probably the biggest thing that this population really was concerned about, or what mattered to them, is finances, particularly finances for retirement. Most did not, at least 76%, did not feel that they had enough finances to basically that they needed long term for supportive care. And so one of the big issues that came out of this study was concerns about retirement. Was there enough money to really, really be able to retire comfortably? A second issue, advance directives. And so these are plans, for example, that you determine what happens and what you want if for example, a catastrophic event happened. If, for example, excuse me, you had a heart attack or something like that, it's very, very important that it be documented what it is that you want done. Do you want to be put on a ventilator? Do you want every life-sustaining, life-saving endeavor to be done for you, or do you not want that invasive kinds of procedures if you, for example, experience a catastrophic health event? So those should be documented and should not be on your family at the time when there's a significant incident where they have to make the decision. No, it's important that they know exactly what it is that you want. Another, estate planning. And I can't tell you how important this is because you want to make sure that your assets, things that you have worked a lifetime for, you want to make sure that your assets go to where you want them to go. Historically, in the past, particularly in the early epidemic, where persons, if they were diagnosed in 81, 82, throughout the 80s and part of the 90s, if you were diagnosed with HIV, you had months to live, if that. And so oftentimes what happened, particularly for the population that was most impacted, when if they were estranged from their family members, oftentimes what happened is their family, perhaps they hadn't spoken to them for years, but when they passed, if there was no estate planning, all of their assets went to people that they didn't necessarily like, or that didn't like them. But, that is one of the issues that happen if there's no estate planning. Also, relocating or being placed in a nursing home, that is an absolute milestone and change for persons where either the family or the medical team finds it necessary that the person can no longer take care of themselves in their environment and being placed in a nursing home. And I tell you, um, one of the important things, and this is something that the provider can convey to the family, if in fact persons do go in a nursing home, how important it is that the family be there, that the family be proactive, that the family be aware of their medical needs, their medical conditions, because oftentimes in some uh, nursing homes, they may not get the appropriate care that they should if there's no family involved. And again, we talked about the lack of sleep. And we also already talked about co-occurring conditions, so I'm not going to really spend a lot of time on this slide, but just know that conditions in this particular study, one of the highest, 62%, really had to deal with high cholesterol. So diet is also very important. Mental health, we talked about depression, anxiety, and another issue was loneliness in this population. So for example, my parents are gone, my grandparents are gone. My grandmother had 17 children that she raised. 17. Of those 17, there are 3 left. And my aunt, uh, who is the only female that's left, is 101. And my 2 uncles that are left from that 17, both are over 90. So one of the things I've had to deal with is a lot of grief, as well as living life. And the most important people in your life are gone. The only people, I'm from Philadelphia, so when I go back, really the only people, I do have a brother. I have 2 brothers and 3 sisters. And so there are my family, and I have cousins. But in terms of parents and grandparents, they're all gone. And so the other issue that I'm dealing with is also hypertension, high blood pressure, and back injury. And so I've got chronic degenerative disc disease that's very severe that oftentimes limits what I can do. And, I live basically in a perpetual state of pain all the time, because one of the issues that may impact me, will certainly impact those with a substance use disorder, is after they've had surgery or some kind of medical intervention, as they deal with chronic pain and they have to use prescription medication, that's very dangerous for those of us that are in long-term recovery. And so it's very important, number one, that our physicians and our providers be well aware that we are in long-term recovery and monitor very closely our use of, for example, opioids. And so I want to just take this time for you to look at and evaluate this video. And so one thing that we rarely talk about that is oftentimes overlooked are those persons that were born with HIV. And so we call them dandelions. And their system and co-occurring conditions and immune system, if a person is 30 years old, it may mimic that of a person that's 60 years old because they've had HIV their entire lives. So you got a 30-year-old, you got a 60-year-old with basically some of the same kinds of conditions based on the fact that both of them have had HIV for 30 years. So I'd like you to listen to this, but I also would like, as you are listening to this, it's very brief, for you to write down what first comes to mind and just put it in the chat. Just throw it in the chat. So when we're finished with this, we can go right to the chat. But as you are listening, what pops up? What concerns you? What are the first things that sort of come to mind as you are listening to this young lady, who, in my estimation, is a trendsetter in the work that she's done. So listen, hopefully everybody can hear it.
In 1992, my mother died of
Everybody here?
complications with AIDS.
Yes.
And I was born HIV positive. So a lot of the poetry that I write and a lot of the work that I do in my life is dedicated to promoting awareness and letting people know about AIDS and HIV. And so here's this poem. It's called Dandelions. A dandelion in the midst of rose bushes would stick out like a sore thumb to ignorant souls. But I know the road this dandelion endured. This weed that all gardeners want to destroy is more appreciated by God than any seemingly beautiful bush of roses. Though that mutely misunderstood mellow yellow dandelion won't for long last, let it be known that God gave it the role of the outcast for divine importance. My mother was a dandelion in the midst of roses. Ignorant of her purpose, she uprooted her soul and unknowingly left herself for dead. It has been said that my mother went above the influence, transmuted broken hearts into smiles, all the while dying on the inside. AIDS didn't kill my mother, it put her at rest. Now this songbird whistles in the key of silence, and I, the latter of five, write poems documenting the struggle unknown to my family. The sickness she denied lies in my blood with a lesser value. People speak. I don't know how you can live with knowing nothing but owning the growing dis-ease that your mother for so long fought. Just the thought alone would destroy me, but see, that's the difference between a rose and a dandelion. Roses were created with thorns to warn hands approach her without caution, but dandelions weren't given that option, but they were created by an all-knowing God, and that all-knowing God created dandelions with the strength to withstand ignorance and hatred. Dandelions live in this matrix of life, understanding the price. Roses live like the world was handed. Dandelions have to take the world and won't leave a rose stranded, but my mother died before she got the chance to realize that dandelions are blessings in disguise. She, I dare say, died before her time. That thought lingers in my mind, conflicting with my belief in the divine. My mom raised me in the faith that the day God sweeps you away is the day proclaimed way before the manifestation. But I can't help but experience devastation, knowing nothing about the woman who carried me, toting guns in the defense of my father. It is even harder knowing nothing about her, but knowing the reason the hospital has become my second home is because this dandelion chose to roam with the buffalo. But I seek serenity in the fact that she just didn't know that she, a dandelion, was just as beautiful as a rose, and I will go forth knowing my purpose as a dandelion. This life is worth all the crying and all the dying I have to do just so someone in my shoes can live. I will gladly give myself as the sacrifice if it means that dandelions in the world will become viewed as more than the consequence of sins behind closed doors. You can lay me on my back and present me lifeless to God if it means that dandelions with unseen scars would not be viewed as odd, but as gifts from God to show the world that beauty lies not in the petals of flowers, but in the power of unconditional love and in the strength of the untouched, unhugged, sometimes unloved, but most important of all, unbudged dandelions. Thank you.
So that was powerful. And her name was Mary, and unfortunately, she passed from a co-occurring condition. And so, but that poem was so powerful. And so, just wanted to know just a couple of comments in the chat. Can we look in the chat?
Yes. So we do have
Just a
we
couple,
do
just because of time.
So as comments are coming in, it's going to be a little tough for me to go back. So give me 1 second. So systemic racism continues to play a significant role in how individuals living with HIV are perceived and treated. Beyond the physical challenges of managing the disease, many face deeply rooted stigma, misinformation, and discrimination, often amplified by racial and socio economic inequalities. This intersection of health and social injustice creates profound barriers to care, support, and dignity, making it clear that addressing HIV requires not only medical solutions but also commitment to equity and education.
Absolutely fantastic. I wish I could read more, but just because of time. But you'll have all of those, hopefully, those comments um, in the chat once you get the actual slides. So let's move on. And so one of the things that I want to make very, very clear when we're talking about HIV, and many of you, I don't know if you've heard the term U equals U, undetectable equals untransmittable. And so unlike it was in the 80s and the 90s, where once you got a diagnosis in the 80s, again, you had maybe months to live. Now we can live a healthy life if we take medications. Medications are absolutely just prolific now, and we become what we call undetectable. That means that the virus is so low in our bodies that that our machines and equipment are unable to detect it. And so that means that's what undetectable means, an undetectable viral load. With that being said, if you are undetectable, you cannot transmit HIV through sex. I want to make that very, very clear. If you are undetectable, you cannot transmit the virus through sex. So this is a milestone. And so in terms of treatment, and antiretroviral therapy is the gold standard in terms of treatment. One of the most important things that we have to make sure that we do is to adhere to the medication exactly as it has been prescribed. And another milestone, July 2012, PrEP, pre-exposure prophylaxis. So this is for HIV negative persons. Very, very effective in terms of preventing HIV. It's not 100%, but it's very, very effective. The important thing is, particularly for the elder populations, that providers make sure that they have a conversation with their clients around PrEP. So, for example, my primary care physician that I've had for 30 years retired. That's another issue, retirement of some of our providers. So I got a new primary care provider. And so I was a little apprehensive. So I went in the office, a little young lady, and she did what I consider a very comprehensive assessment. And the thing that sold me on this young lady, she asked me if I wanted STI um, wanted to be assessed for an STI. And that let me know that she was very proactive in terms of, 72-year-old person that is, she's seeing for the first time. And so really, really what providers have to understand is that sex really occurs throughout the lifespan. And if you think persons that are 60, 70, 72 are not having sex, well, gotta think again, because we are engaging in relationships and sexual activity. So sex does happen throughout the lifespan, but it also happens throughout cognitive decline as well. So let's just get into, so this is a very important, Maya Angelou is one of my heroes. And she says, people will forget what you said. People will forget what you did, but people will not forget how you made them feel. So as providers, it's so important that we convey empathy, that our clients know that we care about them. And there's an old saying, people don't care how much you know until they know how much you care. One of the things about this young lady, my new provider, she really made me feel like she cared. She knew all of my labs before I got there. She knew every medication that I was on before I got there. She knew, and we have this portal within our healthcare system where all of our providers are in one place. All of our medical appointments, as well as the diagnosis and notes, are all in one place. So one provider, as my primary provider, she could see everything. And she was aware of all the other providers that was in my, that's part of my medical care team. And so I was sold on her right away as soon as I saw her. And so let's just take a look at the next couple of slides around substance use around aging persons. So here's some data. In 2020, nearly 3.5 million adults aged 65 and older were living with a substance use. And so why on earth would an elder person even be considered for substance use? Well, there are a lot of extenuating circumstances. So for example, the loss of a partner, the loss of a wife, a husband, and their inability to cope with loss, inability to grieve in a way that's positive. And so this population does have to be assessed for substance use disorder as well. And so just in terms of some of the dangers and some of the warning signs. So oftentimes what happens is physicians or providers may look at this elder person and say, oh, that's all part of aging. But a closer look may tell a different stories. So issues like changes in sleeping patterns, unexplained bruising, hygienic changes, that's a big one. And even issues in these populations around injection drug use is also important. And so just looking at some community resources. In Atlanta here, we have a phenomenal program called Silver Lining. And Joe Robinson, who is a part of the organization, is called Thrive SS. And this project is really a milestone and very formative. It really is to engage those persons, particularly men, those men that are 50 and over. And so it really looks at two salient areas, local support models, as well as social engagement. So again, this population really has issues around loneliness, depression. So this project, Silver Lining Project, really helps to address some of these issues around social engagement, self-love, access to care, all these different things in this particular, and it really is a course that these individuals take. And it really is just some of the elements of that course is in-person trainings, webinars, support group, leadership training. And so again, that is a program that also was developed by those persons that are HIV positive. Those persons that are African American. And so it's really developed by the very people who are impacted by this issue. The other thing, in terms of resources, language matters. One of the things that we want to make sure that we're doing is using person-centered language. And you can see, so for example, we use language that puts the person central. So the person doesn't become the disease, the person becomes someone with the disease. So for example, a person who uses drugs, person who injects drugs, that puts the person central and not the person as a part of the disease. When we're talking about the elder population. Now, I had to come face to face with this myself, and I had to determine what my identity would be around age. Do I only be called a senior citizen? Do I only be called like an old person, an old man? No, my identity is being called an elder. And the elder, when referring to older adults in a cultural context, has different implications. So, for example, elders are knowledge keepers within our community. They're spiritual leaders. They are highly, highly respected. They have our whole oral history, and they function as mentors. And so I wholly sort of embrace this identity at this stage of the stage of my life, because it really encompasses my entire life experiences, my lived experience professionally and personally, and I'm able to convey this to a whole new generation of persons. And so let's just, and this is the last slide. I want to make sure that I have time for questions, but I really, again, want to make sure that we are acknowledging and thanking the people who are the formative kinds of advocates, people like Elizabeth Taylor, who used her starship, who used her money to really, really advocate around HIV in the early 80s when it was unpopular. Magic Johnson, who used his money as well as his celebrity to also increase our awareness, particularly in the African American community, around HIV. Children have really been pivotal in the movement. People like Ryan White, people like a young boy from South Africa, Cozy Johnson. Both of them were kicked out of school because of their HIV, and they didn't just go somewhere and sit down. They fought vociferously. And so, for example, both established ongoing programs which are still in place today. The Ryan White program comes from Ryan White. And of course, one of the first forerunners is Miss Dionne Warwick when she did this song here. That's what friends are for. This record generated millions and millions of dollars for HIV. So we want to thank Gladys Knight, Stevie Wonder, Elton John, who all lent their voices, lent their power, lent their money for HIV. Jennifer Holliday, who still is an advocate around HIV. And of course, we know Elton John, who just has been a drum major around HIV. And still, we've got the Elton John Foundation that's generated millions of dollars for HIV. So we want to acknowledge them and thank them. Also, two of my heroes, Bishop Carl Bean and Joel Williams, Bishop Carl Bean, who started the Unity Fellowship movement because a lot of the funding during the 80s was not trickling down to the Black community. And he really, really made indents in terms of advocacy and programs around HIV. And lastly, Jewel Williams, who recently passed, she was the owner of a club in Los Angeles called Catch One. And it was in the Catch One that provided resources, that provided a safe space for persons that were HIV positive, where they could exchange information and communicate during that pivotal time. And lastly, I want to just acknowledge Bayard Rustin, who told us that in every community, we need an angelic group of troublemakers. And that is you. That's me. That is us, not saying that we're just going to accept everything that's dished out to us. During this time when, a lot of our programs are being defunded, we still have to continue the fight. We still have to, what some people call engage in good trouble. But, maintaining our own self and wellness and rebooting ourselves so that we are continue to be a part of the struggle. And so this is my information. I now have my own LLC, Passion and Purpose Consulting, and you can take a slide of that. And I do presentations on this and other topics throughout the entire world, actually. And so certainly you can contact me anytime that you like. And so we've got not a whole lot of time, but is there any questions?
Yes, thank you so much, Dr. Bryant, for that very informative and engaging presentation. We do have one question in the QA. In light of recent budget cuts to rank-wide funding and broader reductions in healthcare spending across the country, what strategies would you recommend to help address health inequities, particularly among the aging population with HIV?
That's a good question. And I don't know that I have an answer because I don't believe that we have appropriately addressed the issues or the elephant in the room. Now, what we've done here in Atlanta, there have been several people, Alicia McKinley Beach, as well as Dr. Daniel Driffin, have come together, and we've had several community meetings of like-minded organizations and individuals who've come together to develop strategies, particularly strategies around funding. This has been our big effort. We've got to make sure that we're having funding, that we have funding that's not dependent on these external forces that seek to take funding away at their own whim. And so that's one big part of this ongoing strategies that we're doing here in Atlanta and these meetings that we're having. The other thing is we're making sure that our resources are sort of culminated so that we are taking advantage of every resource that we already have. We've got, programs like, Silver Lining, organizations, they may have had their funding cut, but they're doing some really, really proactive and prolific work. And so bringing those resources together, making sure that we're engaging in activities that have impact. We've been talking about the issue of HIV for over 40 years. We've been meeting for over 40 years, but now we want to make sure that our gatherings, our information, our education has impact, has measurable impacts, and has outcomes that are efficacious or that are effective outcomes, because it should not be that the face of HIV has changed now so that it really looks like, Black gay men. And so we really, really have to come up with more creative strategies that, again, are impactful and that are effective for our community.
Thank you, Dr. Bryant. So one last question in the QA. Do you have any book recommendations for the group?
Good question. One, I don't have a book, but I do have a television program that speaks to the HIV, AIDS, and substance use epidemic from its beginning. And that's called Pose. I don't know if anybody's seen that series. It just was one of the most impactful, one of the most prolific and well done series that looked at our community, right, during a time when HIV was rampant and how we dealt with it, how our community dealt with, particularly how the ballroom community dealt with it, the role that they played in saving the lives of people. And I want to say that that Pose is on YouTube. So you can pull it, you can just go to YouTube and put in Pose and pull it up. I'd recommend, I don't all the time recommend binge watching, but if you're going to binge watch, this would be a series to binge watch. And Billy Porter just does a phenomenal job in just the acting and just how this unfolds in terms of addressing the HIV/AIDS epidemic, as well as other issues around the social determinants of health.
So thank you so much. With that said, we're gonna go ahead. We don't have any other questions. A lot of engagement in the chat. So thank you so much for that, Dr. Bryant. I will say that Ashley has already added the evaluation link in the chat, as well as the registration link for our next session that will be on November 7th, and that is going to be Street Medicine and Caring for HIV and Substance Use Disorder in the Unsheltered, again at 12 p.m. Eastern Time. It is always a pleasure to have Dr. Ryan back on our series, and we look forward to him joining us in the future. And we also look forward to our participants joining us for the next sessions. We will be sending out the link for the recording, for the slides, and the evaluation in the post-webinar email that will come directly from Zoom. If you have any questions, feel free to reach out to us.